Today we are looking at the fundamentals of ophthalmology, and then getting towards the end, I'll touch briefly on refractive error and presbyopia. Um, I realized that doing all the fundamentals and adding the refractive error will make it a bit loaded. So I'll talk briefly about refractive error and presbyopia, and then later when we have the opportunity, we can go much into details. This is going to be the outline for the presentation. So some introduction, and then we shall review the anatomy of the eye. We shall look at epidemiology of blindness and visual impairments, and then we shall look at refractive errors as well as presbyopia. I want to hide this. It's actually obstructing my. Okay. Yeah. Yeah. So the eye care team is made up of uh, some individuals that all of us as family physicians should be familiar with. It will help us know who to refer cases to and how to even to interact with them. So usually we have the ophthalmologist as the leader of the eye care team. The ophthalmologist is a doctor or a physician who are specialized in the medical and surgical care of the eye. Then we have optometrists. These are healthcare professionals who theirs is mainly to diagnose, treat, and manage changes with vision. An optometrist usually is not a medical doctor. They usually prescribe glasses and other optical devices. But when you come to this part of the world, because we don't have a lot of ophthalmologists around. I'm talking particularly with respect to Ghana. Optometrists who are around do more than what they are supposed to do. They are actually so much involved in primary eye care. So they diagnose diseases of the eye, prescribe medications, and all that. Even in some places, some are even pushing for optometrists to begin to do some surgery. But by their training, they are not physicians or medical doctors. Then we have opticians. These are people who have been trained to design, to verify, and to fit eye glass lenses, frames, contact lens, and other devices that are used in correcting eyesight. So the the optician will usually depend on prescriptions from the ophthalmologist or the optometrist. They do not test vision or write prescription for visual correction, and they are not permitted by their training to diagnose or to treat eye diseases. Then we have ophthalmic nurses, who are nurses who have done further training in eye. They assist ophthalmologists and the other eye care team in providing a comprehensive eye care. I hope you can all hear me very well.
Yes, it is.
Hello. All right. Yeah. And just like any clinic, we will have the non-clinical staff who provide supportive services. Like
yes, we are hearing you.
Very good. Very good. If at any point you have any question, don't hesitate to prompt me. Yeah. All right. So so an ophthalmologist may practice as a general ophthalmologist or a comprehensive ophthalmologist. And a comprehensive or general ophthalmologist, they usually treat a wide range of eye problems and conditions. Then we have some ophthalmologists who go on to subspecialize in certain areas of eye care. For example, you may have an ophthalmologist whose main subspecialty is taking care of children's eyes. So that person will be called a pediatric ophthalmologist. We have some who will decide to specialize in the cornea and external eye. There are some who specialize in cataract and refractive surgery. We have glaucoma specialists. We have neuro-ophthalmologists, oculoplastic surgeons. They deal with mainly the parts of the external eye and then aesthetic correction of the eye. So ptosis, which is drooping of the eyelids. And then when someone has lost an eyeball from any cause, and then You know, one of the functions of the eye is aesthesis. So the eye is not only for vision. So even though someone's eyeball may be damaged or may become tricycle or small, the person needs to look normal. That's where oculoplastic surgeons come in to fit prosthetic eyes. So the eye, which will not see, but unless you get very close, you will not know from a distance that the eye is not normal. So those are the oculoplastic surgeons. Then we have some who specialize in uveitis and immunology. I've already talked about the pediatric ophthalmologist. Then we have some ophthalmologists who specialize at the back of the eye. Those are the vitreoretinal surgeons, and then we have those who do medical retina. They all have various roles. This is just to give you an idea that although the eye is very, very small, you can spend the rest of your life learning ophthalmology and never finishing. So the purpose of our interaction over the next few weeks is to give you an overview of what we do in ophthalmology. And as a primary or as a family physician, you will have a lot of patients coming to you because by your training you are a jack of all trades. You are supposed to know so much about everything. There appears to be a lot of noise.
Yes, please. Those with the account of Jacob Montgomery, could you please keep it muted unless you have a question? Thank you.
Yeah, thank you. So as family physician specialists, you are supposed to know so much about everything. I recognize that your specialty may be the most difficult and perhaps the most interesting because you never get bored. If I'm in ophthalmology and I get bored with the eye, I have no other option than continue to be in ophthalmology. But as family physician specialist, you touch on every aspect of the eye. So even though there are lots of subspecialties in eye, I promise you that by the end of our interaction this month, we will at least have some basic knowledge about ophthalmology so that wherever we are practicing after our training, we'll be very confident when we have to encounter people with complaints about the eye. What is the role of the family physician in eye care? It's been estimated that about 2 to 3% of all people that will come to a primary care office will complain of some eye-related condition, about 2 to 3%. That's not quite a small number. And what is most important is those few people that complain, as a family physician, you are supposed to know which of them are urgent and which are not urgent, which of them are sight-threatening, and even which of them could be life-threatening. The eye is a window to the body. There are lots of things that happen inside the human body that may first manifest symptoms in the eye first. Yeah, so it's very, very important that we have some good knowledge of ophthalmology. And then with that knowledge, you know when to refer to an eye clinic where you have an ophthalmologist seeing that particular patient. So you are supposed to be able to recognize conditions that can lead to visual loss and therefore require urgent referral to an ophthalmologist. Certain conditions could be blinding and visually impairing, like cataract, refractive error, strabismus. These are, in fact, if you look at the global data, the leading cause of visual impairment and blindness are refractive errors and cataracts. And these are conditions that can be easily diagnosed by the family physician specialist. Okay, strabismus, the eyes not being well aligned. So I think if we are able to pick this, then we can appropriately refer timely to an ophthalmologist so that the patient will have a comprehensive care. So usually for your practice as a family physician, you may not have all the sophisticated equipment you find in a typical eye center, but at least these are some basic ones you should have. You should have a Snellen's chart for checking the visual acuity, because most people will come to the eye with complaints about poor vision. Okay, so the only way you know that's what the patient is saying is true is to objectively measure the visual acuity, and we use the Snellen's chart. I hope from medical school days, most of us are familiar with what the Snellen's chart is, and even how vision is actually recorded. On the Snellen's chart, we have the patient being seated at a distance of 6 meters or 20 feet from a chart. The chart contains a number of optotypes or certain letters. It can be symbols. It can also be some E with the 3 legs looking in different directions. So depending on whether the patient is literate or not, you choose the appropriate chart. And from that distance, from that pre-measured distance of 6 meters, the person will read the optotype. Usually the first optotype is the biggest, okay? So depending on which particular optotype the patient is able to read, there is a score beside it. So if someone is able to read, and we test one eye at a time. If someone, I think if you can see right behind me, sorry, I think my screen is not showing my background, sorry, but I know all of us have seen what the Snellen's chart, how the Snellen's charts look. So if someone is able to read maybe just the first optotype or the first character, then we say the person's vision is 6/60. What that simply means is that that patient is able to read that particular letter or optotype at a distance of 6 meters, what the normal eye should be able to read 60 meters away. 6/60 visual acuity is equivalent to 20/200 visual acuity. So if it's 20/200, that is measured in feet. So it means that that person is able to read that character at a distance of 20 feet. What a normal eye should be able to read about 200 feet away. I hope that is clear. So, and some of the basic equipments again include a Snellen's chart, a tonometer for measuring the eye pressure. Now we have lots of portable tonometers, fancy ones like the eye care tonopen, which are not quite difficult to use. So I think in your practice, if you have that, you can use it to measure people's eye pressure and then refer appropriately. You need a pen light, just like in general practice. You can use the pen light or the pen touch in examining the external eye, and also most importantly in examining the pupil. The pupil is so much important to us as ophthalmologists, especially when it comes to neuro-ophthalmology, because so we get so much information about the behavior of the pupil that can even point to things that could be life-threatening, like a tumor inside the brain and a host of other issues. So you need your pen light, you need your direct ophthalmoscope, and you need your dilating drops. So atropine, which we don't usually use in routine clinic dilatation because of its duration of action. If you put a drop of atropine on someone's eye, the effect can linger for about almost 2 weeks. So there are some short-acting dilating drops like Midracel, which contains tropicamide, and then you can also use cyclopentolate or phenylephrine in dilatation. Then we have another dye. It can come as eye drop or as a strip. The dye could be impregnated on a strip. We call it fluorescent dye. This one is very, very important when you want to examine the cornea, okay? If there are any aberrations on the cornea, or sometimes if there's any foreign body staining the eye with the fluorescent dye, a substance which fluoresces will absorb wavelengths, a particular wavelength, and then emits energy at a different wavelength. So the fluorescent usually will appear orange, yellow. Okay, but when you shine blue light on it, and you can have blue light from your direct ophthalmoscope, when you shine blue light on it, it tends to become greenish to yellow. Okay, so you can stain the eye. If you suspect any aberration or defects on the surface of the eye, fluorescent comes in very handy. And as family physician specialists, we know how important history and examination is. It's the same with eye. When it comes to the eye, your history is very important. It helps us in making diagnosis. The history is just like in any other history. but we put emphasis on what we call the past ocular history, where you ask about any problems the patient may have had with the eye, whether he's been given glasses or contact lenses before, whether he's had trauma to the eye, whether he's had any eye surgery, or whether he's been diagnosed to have any disease of the eye. Yeah, all that comes under the past ocular history. And then when it comes to drug history, you want to ask about systemic drugs that the patient is on. Certain drugs can have effects on the eye, as well as drugs that the patient may be using for the eye. You need to establish this. For example, when someone comes to you and then the patient says that I'm on Timolol, or I put Timolol on my eye. Timolol is a beta blocker which is used in treating glaucoma. So that gives you an idea as to what the patient has been managed for before even coming to see you. So drug history is very important. And then when it comes to family history, you want to find out about history, certain eye conditions that can run in families, like glaucoma, age-related macular degeneration, and then refractive errors. Family history is very important. And even family history of blindness of unknown cause can be very, very important, because especially in this part of the world, there are people who are blind, they have no idea why they are blind. It could be glaucoma. So when you have a patient who gives this particular history, you have to pay particular attention to this patient. Otherwise, he could also end up being blind. So comprehension of the basic anatomy of the eye is very important for us, or for you as primary care physician, in order to be able to perform a complete physical examination. And for you, there are some basic things that you should do. You should be able to inspect the eyelid for abnormalities. You should be able to inspect the sclera for abnormalities like inflammations. You should be able to inspect the cornea and the conjunctiva for abrasions, for hemorrhage, for erythema, and for growths or lesions. Yeah, and then when someone comes with history of foreign body in the eye, you should be able to evect the upper eyelid and see whether that space between the upper eyelid and the eyeball, we call it the superior conjunctival fornix, whether there is any foreign body which is hiding in there, that you should be able to take out, because taking it out actually relieves the patient of pain and also helps to prevent abrasions on the cornea, because as long as you have a foreign body hidden there, as the patient blinks, that foreign body scratches on the cornea. It can lead to corneal abrasion and can lead to scarring of the cornea, and it can eventually lead to blindness. I hope that is clear. Can you all hear me?
Yes.
Hello.
Yes.
All right. Are we all on the same wavelength?
Yes.
Very good. Yeah. So we look at the visual system. The eye acts just like a camera. Okay. And everyone has two pairs of eyes. May I ask, why do you think we have two eyes? Can anyone help me? What is the importance of having two eyes?
Well, if we are to look at, let me unmute myself. Sorry. So if we are to look at it,
yeah, Patrick. Yeah.
Yes, sir.
Yeah, Patrick, I'm listening.
If we are to look at it from the brain,
yeah,
from the brain side, because there is a way that the brain can only see a particular part of the body.
Okay.
While the other side actually visualizes the. So if we don't have two pairs of eyes,
yeah,
the way the brain is programmed can only see a particular section.
Yeah.
And the other section will be completely blinded out.
Very good.
Because the optic chiasma, the crossing of the optic nerve,
yeah,
if we don't have two eyes, meaning that we'll have partial blindness in one visual field.
All right. All right. Thank you, Patrick. Yeah, to a large extent, that is very true. Having two eyes, I think what I can make from what Patrick said is having two eyes actually increases your peripheral field of view. Okay, someone who is monocular or has one eye doesn't have a wide field of view as someone who is binocular. The field of view for the two eyes overlap, and each eye supplies some additional temporal peripheral view, but the nasal field of vision usually overlap. And most importantly, when you have two eyes, because you have the two eyes it's like two cameras looking at different aspects of the same thing, the brain is able to fuse it and give you a three-dimensional view of what you are seeing. So you get stereopsis from using your two eyes. There are other means of getting stereopsis. Okay, someone who is monocular just by judging from distance or relative size can also have some amount of stereopsis, but having two eyes gives us a wider peripheral field of view, and it also gives us good three-dimensional vision or stereoscopic view. One person told me that, well, if you have two eyes, one of them serves as a spare. One eye is not as a spare. Was not made as a spare. But usually, if someone loses vision in one eye, the other eye, the person may be able to cope. But the two eyes, for someone to be visually complete, you should have the two eyes working very well and working together. Someone may have vision in the two eyes. For example, when someone has a palsy of maybe the lateral rectus muscle that is responsible for abducting the eye, that's turning away the eye. If someone has a problem with that, the eye which is turned away will see clearly. The eye which is not turned away will also see clearly. However, the person will have confusion because the person will be seeing double. The brain will not be able to fuse the two images. So the person will complain of diplopia or double vision. So we need vision in each of the two eyes to be perfectly normal, and they should be well coordinated in terms of movement of the eye, so that one can have a binocular single vision. Okay, so having two eyes is very, very important. I want us to now narrow into the eye. We want to quickly look at some relevant anatomies of the eye. Sorry, my screen is not moving. All right, good. Yeah, so for the eye to be able to work well, the eye's dimensions must be maintained. So if you have had a look at the eye, the eyeball is very small, and it is covered by a very hard coat called the sclera. It's mechanically very, very strong. And then we also have fluid inside the eye that keeps the eye at a particular pressure. When the pressure is either too high or too low, the eye is not going to function well. Okay. In children who have congenital glaucoma, we shall talk about this in subsequent lectures, but in children who have congenital glaucoma, because the outer covering of the eye or the sclera is not very, very strong, the pressure increase will cause the eyeball to increase in size, what you call ophthalmos, or the length of the eye from the anterior part, the cornea, to the posterior part of the eye will become unusually long. And those children will not be able to see well, because the eye is supposed to have a particular shape, a particular size that must be maintained, okay? And the optical pathway should be clear. The optical pathway, I'm talking about the media, the ocular media. When light enters the eye, it passes through the cornea, then it will pass through the fluid in the first compartment of the eye, moving anteriorly. That is the aqueous chamber. It contains the aqueous humor. The aqueous humor is very, very important. That is what nourishes the cornea, the iris, and some part of the lens. Okay, and then the light will now pass through the circular opening in the center of the iris called the pupil. Then the light gets to the lens. Okay, the lens is going to refract. In fact, most of the refraction of light, refraction simply means bending of light rays. If light rays don't bend, for them to focus or meet on the retina, you not have a sharp image being formed. So the cornea refracts light that enters the eye to some extent. Then when it gets to the lens also add on to the refraction so that a final pointed image will be formed on the retina. Before the light can get to the retina, it has to pass through another medium we call the vitreous humor. Okay, it's supposed to be transparent, and then it will get to the retina. The retina itself is a transparent medium. Right under the retina, we have a tissue we call the choroid, which is highly vascularized, contains lots of blood vessels. That is responsible for nourishing the retina and ensuring that the retina is always in good shape to be able to perform its photochemical functions. Okay. Now, after the image is formed on the retina, a message is passed on from the retina through the optic nerve into the brain. Okay. So any problem at any point of this pathway can result in impaired vision. When the message gets to the brain, the visual center of the eye, which is located at the occiput, at the occipital cortex of the brain, is supposed to interpret whatever you are seeing. So someone may have a very normal eyeball, the media is clear, the optic nerve is okay, but if there is a problem with the cortex, with the visual cortex, the person will not see. So in that case, if you just examine in a clinic, you will not see any problem, and the patient is also not seeing anything. So the patient doesn't see, and the doctor doesn't see. Okay, so in children who have cerebral palsy, who developed injury to the brain during the time of birth, and for the same reason why they have delayed development, they are not able to walk early, they are not able to hear, and they have seizures and all this stuff. For the same reason, their vision is going to be impaired because the cerebral cortex, which is responsible for vision, has been affected. Okay, and as I said, the visual information needs to be integrated by the two eyes so that you can have a binocular single vision. So again, going from outside inside, the first part that you encounter is the eyelids. So right on top of the eyelids, we have the eyebrow. The main function of the eyebrow, perhaps apart from its cosmetic importance, most ladies who want to apply, what do you call it, want to shave and even paint the eyelash, the eyebrow, because it makes them nice. That could be a non-clinical importance, but I think the eyebrow, the hairs there, help to redirect maybe fluid that may contain dirt coming down straight to your eye. It helps to redirect it away from the eye. That is one function that I'm aware of. Otherwise, it doesn't have any other major function. The eyelid is responsible for closing the eye. That means it mechanically protects the eye. The eye is very sensitive, the cornea especially. If the eyelid does not, if you don't close the eye when a threat is coming, the eye is going to be damaged. Okay, so apart from mechanically protecting the anterior globe, whether from trauma or from even excessive light, when someone suddenly shines light in your eye, you blink, because too much light getting into your eye is not very good. Another function is that it helps to spread tear film. Okay, the cornea needs to be kept moist, and the tears that are produced by the lacrimal gland, where my mouse is pointing, that's the position of the lacrimal gland. It produces tears, and the tears are supposed to wash the surface of the eye, and afterwards they should be drained away from the surface of the eye through some holes here we call the puncti, okay, through the lacrimal system, okay, away from the eye. So it's the responsibility of the upper lid to spread tears uniformly on the anterior surface of the eye. So any problem with the eyelid can result in dry eye syndrome or irritation of the surface of the eye. Okay, all right. So this is the structure of the eyelid. So from anterior to posterior, we have the skin, and then we have the orbicularis oculi muscle. That is the muscle responsible for closing the eye. We have part of it in the eyelid itself, and then we have parts also surrounding the periocular area responsible for closing the eye. Then we have some glands. We have the meibomian glands that produce some lipids, okay? The lipids are components of the tears. The tears that you see is not just pure water, but it contains a lot of substances that help to nourish and protect the surface of the eye, okay? So it has some, it's largely made of water, aqueous, but it contains mucin. The mucin helps the tears to actually stay on the surface of the cornea. And the lipids also help to reduce the rate of evaporation of the tears. When you have water in two containers, one of them contains oil, the other doesn't contain oil. If you expose that water to the environment, the one that doesn't contain oil is going to evaporate faster or dry up faster. So people who have problems with their meibomian glands and hence will have deficiency of come with complaints of dry eye syndrome. It's a condition that we shall look at in details quite later. I hope we are all on the same wavelength. If you have any question at any point, kindly prompt me. All right, so that is what I was talking about. So the eyelid, then we have the punctum or the puncta. We have a superior and the inferior puncti that allows tears to drain into a canal we call the canaliculus. Then it will go to the lacrimal sac and drain down to a space behind the nose, okay? So don't be surprised when you put some eye drop on somebody's eye, the person tells you that he can taste the eye drop, okay? Or sometimes you put a dye like fluorescein on someone's eye because of the drainage. When the person blows the nose, later you see the dye coming out. So there is a connection, okay? When we go to pediatric ophthalmology, what the family physician must know, I'll talk about nasolacrimal duct obstruction and how it presents in children. This anatomy will be very relevant, okay? So I've already talked about the lacrimal gland that is responsible for producing tears, but we have accessory lacrimal glands. These are found on the conjunctiva, okay? They also supplement the production from the lacrimal gland. The lacrimal gland actually produces more tears as a reflex, but when the eye is at rest, there is a basal secretion of tears. That one is mainly from the accessory lacrimal glands. I think I've talked about the punctum, canaliculus, lacrimal sac, and the lacrimal duct. This is the lacrimal duct. Please, can you see where I am showing? Can you see where I'm pointing to?
Yes. Yes.
Very good. Yeah, very good. Yeah, good. And then yeah, there's something here. Let me comment on it. So before the tears can drain away from the surface of the eye, the orbicularis oculi muscle, the facial, the nerve that is, sorry, the muscle that is supplied by the facial nerve. It's also very important in terms of drainage of tears from the eye. So this one will be very important for you as family physician specialist. You may have a patient with stroke that involves the 7th cranial nerve. And because the 7th cranial nerve supplies the orbicularis oculi, they may have what you call lack of thalamus. They will not be able to close the eye properly. But as the eye closes, some suctioning effect is produced that causes the tears to be drained from the surface of the eye into the lacrimal drainage system. So through the canaliculus into the lacrimal sac, then into the nasolacrimal duct. So if there is a palsy of the facial nerve, it means that suction mechanism is going to be defective. So that person will come to you with complaints of tearing because where the tears collect, the inferior fornix, where my arrow is currently pointing, the inferior fornix becomes full, and then the tears have to now drip down the face over the lower eyelid. We call that epiphora. So someone with a facial nerve palsy or from any cause, including stroke or Bell's palsy, can have that particular symptom, and you now understand why that happens. Yeah. So it means for such a person, we need to give some eye drops that are like normal tears to supplement their normal tears, because because they are not closing the eyes very well, the surface of the eye can become very dry. Okay, so they will need tear film supplements like we have Cool Eyes, metal cellulose eye drops, and then you can also give them ointments. Most importantly, you have to give them ointment, especially at night. So ointments like tetracycline ointments when they are sleeping, so that the cornea does not become exposed. Okay, if the cornea is exposed, it will desiccate, it will dry up, and it can become infected, keratitis. That can lead to blindness following scarring after that infection has resolved. So this is a very, very important point I want us to take note. All right, I think I have summarized this slide already. So the tears usually contains 3 layers. So we have the lipid layer to reduce evaporation, the aqueous layer, and the mucous layer. So the mucous layer helps the tears to spread evenly on the surface of the eye. But it's not actually distinctly 3 layers. They are actually mixed. It's a homogeneous mixture, okay, from recent studies that we've had. It's not 3 distinct layers, but it's a homogeneous mixture of the lipid, the aqueous, and the mucous layer. Good. The eyeball itself, like I said initially, has a fibrous coat. Okay, and that coat is made up of the cornea anteriorly and the sclera posteriorly. The sclera appears white, and the cornea is transparent. But histologically, they are all almost the same in terms of the content. They are all made up of collagen fibers. But why is it that the cornea is clear and the sclera is opaque? The sclera is usually white. The reason is that in the cornea, the collagen fibers are well arranged. Okay, they are regularly arranged, unlike in the sclera where the fibers are arranged haphazardly. Okay, because we need the cornea to be clear to allow the eye to see. That's why when someone has a scar on the cornea, they don't see, because the cornea is not transparent enough, and light that is entering the eye gets scattered, and that can lead to blurred vision. So going from outside to inside. So this is the fibrous coat made of the sclera posteriorly from the limbus, or like from where the cornea ends. We have the sclera all around. Okay, but at the posterior part of the sclera, there is a part which is weak, or like which has an opening to allow the axons of the retina to exit the eye. Okay, apart from that, it's strong all the way around it. It's just a particular place of weakness where the optic nerve exits the eyeball. We call that place the lamina cribrosa. All right. So beneath that outer coat, we have a vascular coat, or the uveal tissue, which is made up of the iris anteriorly. So this is the iris, the brown part. So in blacks, it's usually brown, but in Caucasians, it usually looks like blue. It's all because the blacks have melanin in our iris, but the Caucasians lack or don't have lots of melanin. Their iris appears blue. Okay, and in people who have albinism, because they don't have a lot of melanin, even if the person is black and he's an albino, you not have that brownish pigmentation of the iris. Okay, so we have the iris anteriorly, the ciliary body, and then the choroid. I've already talked about the function of the choroid. It nourishes the retina, and it helps to carry waste products of metabolism away from the retina. The retina is a highly metabolic tissue, so you need the choroid to be up and doing, supply it with all the oxygen and all the nutrients it needs, carry out or carry away the waste products as quickly as possible. Otherwise, accumulation of the waste products can lead to damage to the retina. Okay, then we have the nevus coat. That's the retina, the inner lining of the eye. Okay, I'll not bore you with the detailed histology of the cornea, but as I said, the cornea is a transparent tissue. Its main function is refraction. In fact, when it comes to refraction of light inside the eye, the cornea contributes to about 2/3 of the total power of refraction of the eye. You may have thought it's the lens, the lens only contributes to 1/3. Okay, yeah, the lens contributes to just 1/3 of the dioptric power of the eye. So if there is any problem with the cornea in terms of the shape and everything, it can lead to refractive error. I hope that's clear. I've talked about the sclera. So the iris, I've talked briefly about the iris. Within the center of the iris, we have the pupil. Okay, the pupil regulates the amount of light that enters the eye, and the pupil can dilate or constrict. Dilatation of the pupil is under sympathetic nervous activity, whereas constriction or miosis is under parasympathetic activity. Because we examine the pupil most of the time, it's very important we know the pathway for the pupillary light reflex. Okay, when you shine light in someone's eye, okay, there is an afferent pathway and there is an efferent pathway. The afferent pathway commences from the retina. So it starts from the retina. The pupillary light reflex pathway is not the same as the visual pathway. Okay, if you are talking about just the visual pathway, then when an image forms on the retina, the message or the signal is sent through the optic nerve, okay, into the brain. It will get to a point we call the optic chiasma. Over there, the optic nerve will divide or decussate. One will go to the left, one will go to the right. So to the contralateral and then to the ipsilateral side. It will go and then join the visual cortex. But the pathway for pupillary light reflex is different. That one, the afferent pathway begins also from the retina, and then it will pass through the optic nerve, that's cranial nerve 2. But other than also going through the fibers, also going through the optic chiasm, move to the lateral geniculate body. Okay, so this is the eye. That is the optic nerve. Sorry, I think I missed that. This is the eye. That is the optic nerve. Okay, so the pupillary light pathway, it will not cross over at the chiasm. They continue it laterally and then get to a place we call the lateral geniculate body. And then from the lateral geniculate body, other neurons will carry the information to the place we call the pretectal nucleus in the brain. From the pretectal nucleus, there will be information sent to some other nuclei we call the Edinger-Westphal nucleus. So the same amount of information will be sent to the ipsilateral and then the contralateral Edinger-Westphal nucleus. Then that one will now give the efferent. So the efferent pathway of the pupillary light reflex begins from the Edinger-Westphal nucleus. So it will come down through a place we call the ciliary ganglion and then back to the pupil. One thing I want you to learn from this pathway is that the afferent, if you shine light in one eye, because fibers from the pretectal nucleus will move to both the ipsilateral and then the contralateral Edinger-Westphal nucleus. When you shine light in the right eye, you don't expect constriction of the pupil in only the right eye. The left eye is also going to constrict because of what is happening up there. Okay, yeah. Good. The ciliary body is responsible for producing the aqueous humor, helps to maintain the pressure of the eye, and it also nourishes the cornea and the lens. Okay. The ciliary body also gives rise to fibers that hold the crystalline lens in place. The ciliary body also contains muscles. Before one can see something which is near, there is a process that goes on we call accommodation. Okay, accommodation is a stimulus to the eye that will cause the ciliary muscles, the muscles in the ciliary body to contract. When it contracts, it helps to narrow that ring. Picture the eye or the ciliary body as a ring. It's not just a structure there. It's a circular ring. Okay, so when it contracts, it reduces the aperture, and that will cause the zonules or the fibers that hold the lens in place to relax. The lens actually is very pliable. The lens is like some fluid inside a bag that can change its shape. When the zonules relax, then the lens will now assume its normal spherical or like its natural spherical shape. That increases the power of the lens and helps you to be able to focus on things which are near. If you want to look at something which is distant, the lens has to change its power. In that case, the ciliary muscle has to relax. And then as the ciliary muscles relax, the zonules become taut, and that will stretch on the lens and cause the lens to assume a more flatter shape. Okay, so the ciliary body produces aqueous humor that will circulate the anterior chamber, and after performing its work, it needs to drain away from the eye through what you call the angle. So if you have read about glaucoma, you have heard about what you call open angle glaucoma, angle closure glaucoma. This is the angle of the eye. So the angle of the eye is a structure between the cornea. This is the cornea, okay, and the iris. Where the cornea meets the iris, the structure here, there's a sieve-like trabecular meshwork. So the aqueous, after it has performed its function, will have to be drained through that sieve-like or trabecular meshwork into the circulatory system. We have some venous system here. We have the episcleral veins. That's the fluid will now drain away from the eye. And there are two main parts. We have the conventional pathway, which is responsible for about 90% of the outward flow of aqueous. Then we have the uveoscleral pathway. I've already told you that the uvea refers to the iris, the ciliary body, and the choroid, okay? So if there is inflammation of the uvea, we call it uveitis, okay? Yeah, so there is a potential space between the sclera, the outer coat. I hope you can see my arrow. The outer coat and then the choroid. That potential space can drain about 10% of the aqueous that are leaving the eye, okay? Yeah, these two pathways are very important. If the pathways are blocked for any reason, then the pressure builds up, and that is what leads to glaucoma. So good drainage and good production of aqueous humor helps maintain the eye at its normal intraocular pressure of between 8 to 21. On average, for most people, it's about 15 millimeters of mercury. So the average pressure of the eye or of the normal eye is usually between 8 to about 21. Some authorities quote 10 to 21, but the average is about 15. All right, so I talked about accommodation. So when someone is looking at something which is distant, the lens is relaxed because the ciliary muscles are not infinity will now focus on the retina. However, if you want to look at something which is near, then the lens must have a more spherical shape to be able to now focus whatever you are looking at. Thank you. So the next structure I want to talk about is a crystalline lens. The lens is very important. As I said, it is responsible for refraction of light that enters the eye. In addition to the cornea, the lens contributes about a third of the total dioptric power of the eye. The total dioptric power of the eye is about 60 diopters. The lens contributes almost about 18 to 20. The lens, the normal lens is normally transparent, okay? And the lens, as I said, is held by some fibers we call zonules to the ciliary body, so that when the muscles in the ciliary body contract, the zonules also either they relax or they contract. Yeah, when when the ciliary body muscles contract, the total scleral ring of the eyeball diameter reduces, and that will cause the zonus to relax and the lens to assume a more spherical shape, increasing its dioptric power for the eye to be able to focus on objects that are near. All right. So problems that can happen to the lens is, as you grow, the lens can become opaque. Let's look at the structure of the lens. During the time of embryological development, we have the fetal nucleus and then the embryological nucleus. The nucleus, or like the lens, is made up of layers, just like a piece of onion. When you cut onion, you find different layers inside the onion. That's how the lens too is. So the very first fibers that are formed will be at the core of the lens. And then as the lens is developing, new fibers are formed around it concentrically. So the oldest part of the lens is the most central part. Okay, as you grow, some parts of the lens becomes opaque and light cannot pass through. That is a condition we call cataract, which is the leading cause of blindness globally. Okay, we shall have a special session on just cataract. So let's take note of that. All right, I think I've already talked about the choroid and then the vitreous body, or the vitreous humor. It contains a gel-like, a clear gel-like substance that fills the posterior aspect of the eye. It's mainly made up of water, but there are some collagen fibers inside there, and it allows light to be transmitted to the retina. When I mentioned the ocular media, I talked about the cornea, the aqueous humor, the lens, the vitreous, okay? And let me add even the retina too, okay? If any part of the ocular media is not transparent, vision is going to be impaired. So starting from anteriorly, some of the things that can make someone not see. Starting from anteriorly, there can be abrasion or scars on the cornea. It can affect vision. If you move into the anterior chamber, if there is blood, let's say after trauma to the eye, and there is blood in the anterior chamber of the eye, technically we call that hyphema, okay? So when there is hyphema in the eye, it can affect transmission of light through the eye. It can impair vision. It's not only blood that can fill up the anterior chamber. Sometimes if there is uveitis, which is inflammation of the uveal tissue, which I mentioned is made up of the iris, the ciliary body, and the choroid. If especially there is inflammation of the iris and the ciliary body, it can lead to the leakage of proteins that normally should not be in the aqueous humor. And when you have so much proteins in water, it makes the water appear turbid, okay? And light that is passing through will get scattered, okay? So when there is hypopyon, which refers to white blood cells in the anterior chamber, red blood cells in the anterior chamber is called hyphema, okay? So when there is hypopyon from infection inside the eye that we call endophthalmitis or uveitis, then vision can be impaired because the media is no longer as clear as it should be. Then you move on to the lens. If there is opacity of the lens, in this case cataract, then light cannot pass through the eye very well. You move on to the vitreous. The vitreous, two things can happen. Either there is hemorrhage in the vitreous hemorrhage, like when you have diabetes retinopathy, the proliferative type, where they form lots of new vessels on the retina. These new vessels are not as strong as the normal vessels, so they can easily break and release the content of the vessels into the vitreous. We call that vitreous hemorrhage. Or if there is trauma to the eye, there can be vitreous hemorrhage. Or sometimes there can be uveitis, inflammation of the choroid, okay? choroiditis, which is a form of uveitis. It can also lead to a breach in the blood-retinal barrier and allow certain proteins that should not normally be inside the vitreous or be inside the eye to be released into the eye. Let me give you this information. There are a few areas in the body that are immune privileged. Okay, by that I mean that they are well protected from the rest of the immune system. The eye is one of them. So anteriorly, we have the aqueous blood barrier. That's a lot of tight junctions. That doesn't allow just every content of the blood to get into the eye. So things are well sealed before they get into the aqueous humor. But when there is inflammation, like iritis or anterior uveitis, then some of these proteins, because of the weakened barriers, can now get access into the eye. The same way, posteriorly, we have blood-retinal barrier. Okay, if there is any inflammation, that will cause weakening of the blood-retinal barrier. Then you have lots of proteins coming into the eye to destroy it. Okay, some of these proteins affect the vision, and they can eventually end up destroying the eye from uveitis. The other immune privileged sides of the body, I think the brain. We have the blood-brain barrier. Okay, then we have the testes. So certain things inside the eye, just like we have in the testes, should not be exposed to the general immunity. Otherwise, the immune system recognizes it as being foreign and they start producing antibodies against them. That can end up affecting the other structure, in this case, the other eye. So someone who has had trauma to the eye and the uvea is, exposed, the uvea now becomes exposed to the circulating, like to the systemic immunity. So the immune system will now produce antibodies against some of the antigens inside the eye that were protected. And those antigens can now go on to destroy the other eye in a condition we call sympathetic ophthalmitis. It's very, very important. And this can happen within months or sometimes years after trauma to one eye. So when someone has trauma to one eye, not only has he lost vision in that eye, but if it's not well managed, especially when it's an open globe injury, it can also eventually lead to damage of the contralateral eye that was not immediately traumatized. I hope that point is clear. Hello. Hello, everybody.
Yes. Hello.
Yeah. Can I move on? Are you with me? I hope you are not sleeping. I can't see your faces.
We are not sleeping.
Dr. Patrick said you should go back to the explanation of the third junction and the immune.
All right. All right. All right. So I said that the eye is an immune, is one of the few organs in the body that is immune privileged, meaning that the content are tightly protected and whatever comes into the eye is highly regulated. Okay, so from the anterior portion, we have the aqueous blood barrier. Okay, it's not everything inside the blood that gets filtered into the aqueous. It only happens when there is inflammation of the anterior part of the uvea. And I said the uvea is made up of the iris, the choroid, the iris, the ciliary body anteriorly, and the choroid posteriorly. So if there is uveitis or inflammation that involves any of these two structures, then the tight junctions become disrupted and certain components of the blood, like some proteins that should not ordinarily be inside the aqueous, gets the chance to be there, and that can cause damage to the eye, can impair vision. Okay, posteriorly we have the retina, the blood-retinal barrier. Okay, that also has some very tight junctions. So it's not everything inside the blood that gets into the eye. So in people who have diabetes, and develop diabetic retinopathy. They develop the diabetic retinopathy because of the microvascular complications. So certain supportive cells around the retinal vessels are destroyed, and those cells help maintain that tight junction. So when those cells are destroyed, then that blood-retinal barrier is breached, okay? And then proteins and other stuff now get into the eye and start causing lots of damage. There will be ischemia because the blood vessels become occluded and lead to a lot of other. We shall have one session on diabetic retinopathy, and I'll explain this pathophysiology very well. I hope it's clear. And I said we have similar immune privilege sites in the brain and then in the testes. And what is of clinical importance to us as ophthalmologists is that because of this, when there is trauma to one eye and the uvea becomes exposed to the immune system, then the immune system can start to develop antibodies against some of the antigens in the uvea, which ordinarily should not be exposed to the immune system. So those antibodies produced can now go on to affect or to attack the other eye and lead to blindness in that eye as well. And that is what we call sympathetic ophthalmitis. It can happen after trauma or sometimes even after intraocular surgery, okay? It can happen within months after the inciting insult or injury, or several years. It has been recorded that some sympathetic ophthalmitis has developed even for as late as 50 years more. So it's something that can happen, that when you have a patient who has had trauma to the eye, not only has the patient lost vision in that eye, but if it's not well managed, and some of the management could include, if you cannot salvage the eyeball, could include you removing the eyeball, a process or a procedure we call enucleation, so that you save the other eye from becoming attacked by the body's immune system in the process or in the pathology we call the sympathetic ophthalmitis. I hope it's clear.
Yeah, it's clear.
All right, thank you very much. So I move on. So the vitreous body or the vitreous humor is gel-like, and it is attached to the optic disc and then certain other parts like where the retinal vessels enter and exit the eye. The vitreous is more firmly attached to these places. And then behind the lens, there is a place we call the pars plana or the vitreous base, a place called the ora serrata. The vitreous is firmly adhered to these places. If there is trauma, then it can cause these adherent places to become loose, and the vitreous can now start to move. That can present with certain symptoms like floaters and then flashes of light, because as the vitreous move, it pulls on the retina, okay, and that can lead to sensation of photopsia or sensation of lightening. When someone complains of seeing flashes of light, it should tell you that it's a posterior segment problem. Perhaps maybe because of aging. When you grow, the vitreous becomes liquefied. And when it becomes liquefied, then it moves. As it moves, it causes traction on the retina. So the vitreous is here and the retina is here. So any traction to the retina will send impulses to your brain, and you will see it as light, okay? So the retina doesn't respond only to light, but sometimes to physical or like mechanical forces. Anything that will stretch on the retina will produce some light. That's why some people complain of flashes of light, because of pulling of the vitreous on the retina. So the main function of the retina is to convert light impulses into nerve impulses. And as I've just said, it can also convert mechanical impulses into nerve impulses as well. Yeah, so the retina runs from anteriorly, this particular place. If you can see my arrow, this place is called the ora serrata. That's where the retina begins and goes all the way posteriorly okay, to this place. Posteriorly, the retina is made up of many layers, okay, and the most superficial layer of the retina is made of the axons of the nerves, axons of the nerves that are carrying the light signals to the brain, okay. So all of them will come and converge at a posterior part of the eyeball, a place we call the optic disc, and then now leave the eyeball through a defect in the scleral coat we call the lamina fibrosa. This is very, very important. I'll mention this when we are talking about glaucoma, the pathophysiology of glaucoma, okay? So that place is relatively weak. So anything that will increase the pressure of the eyeball will cause damage to the nerves that are exiting the eyeball, okay? All right, I think I'll not bore you with these details. Let me quickly run through these parts. So the retina is made up of photoreceptors, mostly made of rods, and we have cones. The rods are in the majority. The rods are almost about, I think we have almost about 120 million, okay, of rod cells. Then we have about 6 million of cones. Yeah, the cones are responsible for color perception, and the rods mainly responsible for black and white perception and some other functions, okay? Yeah, so the total number of rods is about 120 million, cones is almost about 6 to 7. The cones are very important for vision during daytime, whereas the rods are important for night vision and then detection of movement or spatial vision, okay? And the rods are most of the time more concentrated in the peripheral parts of the retina, whereas the fovea or the macula is the site where we have most of the cones concentrated, okay? Yeah, so I put in this particular slide to demonstrate the fact that some presentations may be very obvious, okay? When someone comes to you with an arrow in his head, and then the person says he has headache, of course, it's very obvious. But certain presentations will require that you look at the fundus of the eye, what we call fundoscopy, okay? So when someone complains of headache, in this particular case, it's very, very obvious. What about the other complaints of headache? Headache could be a sign of something that could be life-threatening, like a tumor inside the brain, or anything that is increasing the pressure inside the brain. And if you have the skill of examining the fundus of one's eye, you can pick some very important signs. That is how a normal optic disc looks like, okay? That is a fovea. So if you look at the retina, there are some vessels, vascular arcades. There are 4 main vascular arcades, each one of them going to each of the quadrants of the retina. So this one is like the superotemporal. The fovea is temporal to the disc, or let's say lateral, okay? Whereas, yeah, so this is a superotemporal vascular arcade. Then we have the inferotemporal vascular arcade. Then we have the superonasal vascular arcade to supply the superonasal portion of the retina. Okay, then we have the inferonasal vascular arcade to supply the inferonasal portion of the retina. Let me make this point. I think I didn't put it in the lecture, but every part of the retina has some space in the visual field that is responsible for, okay? So when you look straight, you can divide your visual field into a superior and inferior, and also into a temporal and nasal. When you have an object on the temporal, in the temporal space of your visual field, and that object is being seen by the eye, the image is going to be formed on the nasal aspect of the retina. Similarly, if you have an object in the nasal aspect of your visual field, the image will be formed in the temporal retina. The same way, if you have an object located in the superior field, superior aspect of the visual field, it's going to form an image in the inferior part of the retina, and vice versa. Okay, so by doing fundoscopy, you can pick that maybe the disc appears edematous or swollen. If you have edematous disc in both eyes, that is what we call papilledema, and it could be a sign of anything, an increased intracranial pressure. So from if there is a space occupying lesion inside the brain from a tumor, or there is something we call idiopathic intracranial hypertension, you may also find swelling of the disc. That could explain the headache. So it's not always that the cause of a headache may be that obvious, but you can, if you have the skill of doing a fundoscopy, which is a very simple skill to learn. Our advice now that there are lots of videos on YouTube. Okay, so if you have access to a direct ophthalmoscope, you can easily learn how to do fundoscopy. Okay, there are lots of, I can give some links to certain YouTube sites that will be very handy in making you learn these things. Okay, so you should have a look at how the normal fundus looks like, so that if you see any abnormality, you know what is could be telling you. Sometimes as family physicians or family medicine practitioners, you may have a patient with meningitis, okay, and you may want to do a lumbar puncture to confirm your meningitis, or certain conditions you may just want to do what do you call it, a therapeutic tap, okay. But before you can do that, you need to ensure that there is no increased intracranial pressure. Otherwise, you put in your needle and there is coning and the patient can die. Okay, so you don't have to refer the patient. I don't know how ophthalmologists are spatially distributed in Liberia, but if you don't have an ophthalmologist around, if you learn this skill, it will help you quite a lot, because you can easily see how the disc looks like. If it's edematous, you will know, and you know when it's not safe to go ahead to do a lumbar puncture. I hope that's clear. All right, so the retina has the most sensitive part we call the macula. That's the part that contains a lot of cones responsible for color vision and then vision during the day. So I said we have 4 vascular arcades. So this is a superiotemporal vascular arcade. So it has a retinal artery and the retinal vein. Then we have the inferotemporal, we have superionasal and inferonasal. Now between the 2 temporal vascular arcades, that's the superior and the inferior, we have a region we call the macula. Macula is a part of the retina that is most sensitive. For the macula itself, at the center, we have a fovea. The fovea has the highest concentration of cone photoreceptors in the macula. Okay, so when someone is looking at something straight, the light that is entering the eye straight hits right at the macula. Okay, so when someone has a problem with the macula, the eyes may deviate so that it can form an image at a place other than the most sensitive part, the macula. Okay, I've talked about the fovea, and that's the optic disc. So the optic disc normally is about 1.5 millimeters in diameter. Okay, it's usually pink or orange in color, and at the central part of the optic disc, there's a small space we call a cap. Okay, and around it, we have some healthy nerve tissue we call the neuroretinal rim. Okay, and then the boundary between the optic disc and the retina should have a well-defined boundary, a clearly defined boundary. Then we have the vessels that are exiting the disc. In a normal disc, you should see all the vessels clearly. You should see the boundary of the disc. If the disc is swollen from any pressure on the optic nerve or from any increased intracranial pressure, the boundary is going to be blurred and the whole disc is going to appear swollen and you may not even see the vessels on the disc. Okay, so we should know how the normal optic disc looks like, so that we can identify an abnormal optic disc. So this one is saying the same thing. So that's a neuroretinal rim. That's a cap. That's the optic disc cap. It's a physiological cap. However, again, we shall talk about glaucoma. But in people who have glaucoma, it is a problem with the optic nerve from increased pressure inside the eye. The increased pressure actually damages the optic nerve, and this cap, which should usually be small, now begins to enlarge. Okay, so there is something we call capping, or in ophthalmology we call something cap to disc ratio. So the diameter of the cap here compared to the diameter of the whole disc. Okay, it should normally be about 0.3 to 0.4. If you have someone whose cap to disc ratio is more than 0.5, it could suggest that the person has glaucoma. All right, I've summarized the vascular supply to the retina. Okay, so that is the optic nerve. So from the optic disc, the fibers will exit the eyeball through a place here. It's a weak place. We call the lamina fibrosa. Okay, as the optic nerve, and as the optic nerve exits, okay, we will have the coverings of the brain also coming to cover the optic nerve. Embryologically, the eye is just an extension of the brain. So you can examine the eye and see the brain. The meninges of the brain come all the way up to somewhere around this point. Okay, so this pink one, sorry, here, yeah, this violet one will go back and cover the brain. That's why if there is any increase in intracranial pressure, you have that the pressure will be transmitted to the optic disc, and the optic disc becomes very edematous. And similarly, when someone has meningitis, because the meninges are inflamed and they are connected to the optic nerve, that's why when the person moves the eye, they will have pain. Okay, photophobia, very, very discomforting feature. Okay, and the optic nerve is made up of about 1 million, some say about 1.2 million nerve fibers. These are connections from the axons of the retina, and they will go all the way in the visual pathway. So we have the fibers coming here, they'll get to the optic chiasm, then they will divide into two. They don't divide into a 50-50% ratio, but you have some moving to the contralateral side and then some continuing on the ipsilateral side. Okay, so about 51% will move to the contralateral side, and 41% of the nerve fibers will continue to the ipsilateral side. So it will come and get to the lateral geniculate body, and then from there we have some fibers continuing to the visual cortex. Okay, so those are the nerve fibers. So if you have any pathology anywhere on the visual pathway, it can lead to blindness in a particular field of vision. I'll be ending this boring anatomy very soon. But it's very, very important when we come to learning about some basic or some common eye condition. That's why I'm taking my time to go through all this. So sorry for boring you. Now we are done with the inside of the eye. The eyeball is able to move from side to side, up to down, because there are muscle fibers or certain muscles that hold the eyeball and control its movement. Okay, so we have extraocular muscles and we have intraocular muscles. There are 6 extraocular muscles. 4 of them are straight muscles, what we call the recti muscles. So we have the superior rectus, the inferior rectus, we have the lateral rectus, and then the medial rectus. We are supposed to know the function of each of these. When the superior rectus contracts, what does it do to the eye movement? The superior rectus is responsible for upward or for elevation of the eyeball. Okay, the inferior rectus is responsible for depression or looking down. The lateral rectus is responsible for turning the eye away, what we call abduction, and the medial rectus is responsible for inward movement of the eye, what you call adduction. So that's how you can remember. So adduction is done by the medial rectus because you are adding the two eyes. The two eyes are now looking towards each other, okay? And abduction is turning the eyeball away. In addition to these 4 extraocular muscles, we have 2 muscles that are oblique. We have the superior oblique muscle, and then we have the inferior oblique muscle. The superior oblique muscle supports or augments the effort of the inferior rectus muscle in depressing the eye. And then the inferior oblique muscle also supports the action of the superior rectus muscle in elevating the eye. They also perform the function of torsion, okay? For the eyeball not to move to the right, to the left, up or down, but to twist on itself, what we call torsion. That function is subserved by the inferior oblique muscle and the superior oblique muscle. Okay, so those are the extraocular muscles. Then we have the intraocular muscles. Some also add the levator palpebra superioris. That's the muscle inside the upper eyelid responsible for opening of the eyelid. Some add it to the extraocular muscles and see we have 7 extraocular muscles. So some say 6, some say 7. So just take note that if it's 7, then they have added the levator palpebra superioris muscle to it. I hope that's clear. All right, so that is enough for the basic anatomy of the eye, clinically relevant anatomy of the eye. I hope it's been clinically relevant. Does anyone have any questions so that I'll quickly conclude with the next part? Is there any question on what we've done so far?
I think there's, just so you know, because you might see some of the chats, there's another training that is starting that some of the residents were going to go to. So I'm just going to say that those who absolutely need to go. Others maybe stay. Both sessions are being recorded, so you can, some people finish this session while others are starting on the other, but both will be recorded so you won't miss anything. And I apologize for it. Maybe next time we have a Thursday session in 2 weeks. If you guys could all just be please on time for this session, because we knew we would be doing this back to back. So we count on you for being here promptly at 2 p.m. In 2 weeks. So please continue. I'm so sorry, Dr. Tengiam.
All right, thank you, Dr. Olga. So I now want to briefly look at blindness and visual impairments. The two are not the same. And when we talk about visual impairment, the World Health Organization defines blindness and visual impairment mainly using visual acuity. So it tells you how important visual acuity is. And I talked about the fact that we use the Snellen's chart in measuring visual acuity. And at the beginning, I said that there are letters that have been of particular size. So depending on what a person is able to read, the person is scored. And usually it is documented as a fraction, okay? The numerator will be the testing distance. So if the person is seated at a distance of 6 meters, or let's say 20 feet from the chart, then the numerator will be 6. And the denominator will be the size of the optotype, or the character, symbol, whatever it is. Some even use numbers, okay, that the patient is able to read and cannot continue reading any down further, okay? So when you have maybe a visual acuity of, let's say 6/60, I'm retracing what I said earlier, it means that that person's vision is so bad that he can only see at a distance of 6 meters what someone with a good vision should be able to see about 60 meters away. So the same thing with vision of 6/12. So that means vision of 6/12 is better than what? Vision of 6/20. Okay? Normal vision is better, should be better than 6/12. So when someone's vision is 6/6, it means that he sees at a distance of 6 meters what the normal eye should see 6 meters away. You may have some visual acuity of, let's say, 6/4 or 6/5. What does that mean? Can someone help me? When you have an eye, and for visual acuity, we test one eye at a time, okay? You close the left eye to test the right eye, then you close the right eye to test the left eye, okay? So what does it mean when someone's vision is 6/4? The same way I explained. I said when someone's vision is 6/12, it means that the person can see at a distance of 6 meters what the normal eye should see about 12 meters away. So what does it mean when someone's vision is 6/4?
Yeah, it means that the person can see at 6 meters, while the normal eyes can see that at 4 meters.
Excellent, fantastic. So it means that that person's vision is better than what the average eye or like what the normal eye should be. Those are like people with super acuity, okay? So we should be able to understand these simple notations. Now we use these notations in classifying visual impairment and blindness, okay? We normally define, sorry, before I go, let me explain this. So what about if you are doing the visual acuity and then the person cannot see the biggest character or the biggest optotype, which is 6/60? You have the option of reducing the testing distance. Maybe let the person come closer, okay? If the person cannot see the first character at a distance of 6 meters, then you can let the person come closer by, let's say, 5 meters, okay? If the person comes closer by 5 meters and he can now see the first character, then you say the vision is 5/60. As I said, the numerator is always the testing distance. If the person now has to move to a distance of, let's say, 3 meters before he can see the first character, then it's what? 3/60, okay? Yeah, if he has to move to a distance of 1 meter before he can see the first character or the biggest character on the Snellen's chart, then the person's vision is what? 1/60. I hope that is clear. All right, good. Now, some people, instead of moving the patient closer to the chart, rather have it that the patient sits down and the examiner rather moves closer to the patient. So they will stand at a distance of, let's say, 5 meters and raise their fingers and allow the patient to count how many fingers they can see. So if the patient is able to count like the number of fingers that the examiner has raised at a distance of 5 meters, then we say the vision is what? Counting fingers at 5 meters. That is almost equivalent to 5/60 visual acuity, okay? If he has to come close to 1 meter before the person can count fingers, then we say that the visual acuity is what? Counting fingers at 1 meter, okay? What about if still at 1 meter, the patient cannot still count the fingers? Then you move on to the next step we call hand motion, okay? So the examiner has to move the hands in a particular direction. You shouldn't be too close to the patient, because if you are too close to the patient, moving your hand will blow air current on the face of the patient, and the patient who is not seeing will notice that something is moving and tell you that you are moving your hand. Meanwhile, the person is not seeing your hand moving actually, okay? So when you are doing this, it should be almost about an arm's length from the patient before you do the hand movement. If he can see that, you document the vision as hand movement. If you cannot see that, then the vision has to, you now have to go on to the next step. Bring your torchlight and shine into the eye, okay, to see whether the patient can see the light. If the patient can see the light, then his vision is what? Or his visual acuity is perception of light. If you cannot see the light, then you have to test for perception of light in all the 4 quadrants, because someone may have a lesion or a problem with central vision, but the peripheral vision may be intact, okay? So if you cannot see the light, test the upper outer quadrant, the lower, shine the light from the lower outer quadrant, the inner outer quadrants, and then the inner, sorry, so upper outer, inferior or lower outer, upper inner, lower inner. So when you shine the light from all those quadrants and the patient is still not seeing, then you can say that the patient has NPL vision, or non-perception of light, or some say perception of no light. Okay, that means the person is totally blind. It's a point of no return. Nothing can be done to bring or to improve the vision in the eye. There's something that I want us to really take very seriously. Okay, so if you find yourself in a place where there is no Snellen's chart, you can do a gross assessment of the patient's vision by just raising your hands. Okay, so let the patient see whether the patient, with one eye closed, see whether you can count your fingers at a distance of, let's say, 5 meters. If he can't, come closer, 3 meters. If he can't, come closer, 1 meter. If he still can't, wave your hand. Okay, if the patient says that he can see your hand moving, let the patient demonstrate exactly what you are doing, whether you are moving it up to down or left to right, okay, to be sure that it's actually hand movement. If you can't see that, then you go on to use your torchlight, okay? All right. Now, we say someone has mild visual impairment when his visual acuity is worse than 6/12, but better than 6/18. So visual acuity of between 6/12 to 6/18 is considered mild, okay? Moderate is between 6/18 to 6/60. And when someone's visual acuity is worse than 6/60, but better than 3/60, or counting of fingers at 3 meters, then we say the person is severely visually impaired. Now, this one is in reference to the better eye. In reference to the better eye. So that means that you can have someone whose vision is maybe perception of light in one eye, but if the other eye is seeing 6/6, you cannot say that the person is visually impaired, because the better eye sees 6/6. I hope that is clear. Yeah.
Yes.
Good. So beyond that, from mild visual impairment, you go to moderate visual impairment, then you go to severe visual impairment. Now the next, in terms of worsening degree of vision, is blindness. The World Health Organization defines blindness as a presenting visual acuity that is worse than 3/60, or counting fingers at 3 meters, okay? Or it can also be defined as if the person's field of vision, okay, visual field, like when you are looking straight, you should be able to see things which are at the periphery without having to turn your eye. If the degree is less than 10 degrees, we can say in the better eye, that person technically qualifies to be labeled as blind, okay? And globally, we have at least 2.2 billion people who have either visual impairment or blindness. That is almost about a third of the world's population, okay? And of this number, majority of them who have the visual impairment, it could have been prevented, or they are yet to be addressed, okay? The leading cause of visual impairment and blindness in total is refractive error and cataract, okay? Worldwide, those are the leading ones. But when it comes to blindness alone, then the leading cause in the world is cataract. So let's take notes. This one can come in multiple choice questions, okay? So cataract is the leading cause of blindness globally, okay? But the leading cause of visual impairment and blindness in total is refractive error, okay? And majority of these 2.2 billion people are people who are 50 years and above. So these are the main causes, and the epidemiology of blindness differs from developing countries if you compare that to developed countries, okay? Because of poor access to good eye care services, we have a lot of people who are blind from cataracts. And cataracts should not, cataracts blindness is reversible, okay? It's curable. Unlike glaucoma, when someone is blind from glaucoma, it is not reversible, okay? So in developing countries, cataract is a leading cause. So we need a lot more ophthalmologists. We need more people in the eye care team to do cataract surgeries for people who are blind. In Ghana, we recently did a national blindness and visual impairment survey. And the leading cause of blindness in Ghana is cataract, just like we have in the global world. And that formed almost about 50.4%. And next to that was glaucoma, forming almost about 19%, okay? Now, trachoma and vitamin A deficiency and onchocerciasis are not so much of a problem in most parts of Africa because of certain interventions that have been made, okay? We have trachoma control programs. We have interventions where children, I don't know how it is in Liberia, but in Ghana, children who go for immunization are given vitamin A supplements every 6 months until they are 5 years. Deficiency of vitamin A can lead to damage to the cornea, scarring of the cornea, and hence blindness, okay? Onchocerciasis, there are places in Ghana and some parts of West Africa where onchocerciasis is endemic. It's a disease that's transmitted by the simian fly or the black fly, okay? They induce uveitis inside the eye and can be potentially blinding. If you look at the developed countries, their leading cause of blindness is age-related macular degeneration. It's a condition that happens to this part of the eye, the macula. Yeah. So they have degeneration of this part of the retina, the macula. Okay, that's their leading cause of blindness. They also have cataracts, but their cataracts is not as much as the burden we have in the developing countries because there is more access to cataract services than we have here. They also have glaucoma, but glaucoma appears to be more in developing countries compared to the developed countries. They, diabetic retinopathy did not make it in the top 5 for developing countries, but it is really a problem in developed countries because they have higher incidence of diabetes and their population ages more. And the more you grow with diabetes, the more you are likely to develop diabetic retinopathy, irrespective of how well controlled your diabetes is. For people with type 2, if you should live for at least 20 years with your diabetes, you are going to start developing diabetic retinopathy. And then they also have refractive error. So this is an eye that has cataract, okay? You can see a whitish opacity within the pupillary space. That's the lens. The lens has become opaque, okay? This is an eye that has a problem with the cornea. So it could be from vitamin A deficiency or from trachoma. In trachoma, there is infection of the conjunctiva, and that causes the eyelashes to become misdirected. And the misdirected eyelashes can be rubbing on the cornea, can lead to abrasion. The cornea becomes infected, and then when that infection heals, what is left is a scarred cornea, which is useless for vision. Okay, so there's an eye with trachoma. So we have infection occurring here. There is fibrosis of this part of the conjunctiva. We have the conjunctiva. We have the part that covers the eyeball. We call it bulbar conjunctiva. Then we have the tarsal conjunctiva. So this part becomes fibrosed, and eventually it will cause the eyelashes to become abnormally aligned, and it can rub on this clear part of the eye we call the cornea and lead to blindness. Okay, this is an eye that has glaucoma. So that is the optic disc. You can see that the cap is very, very big. Okay, at the center of the optic disc, that's glaucoma. Okay, and the effect of blindness is so telling. Okay, especially in developing countries like where we find ourselves, when someone is blind, the person cannot contribute economically. Okay, the person now becomes totally independent. A child who should be going to school now has to drop out of school to help the person to move around. Okay, whether he wants to go to the washroom, or sometimes these children are used by people who are blind to the streets to go and beg. I see that quite a lot in Ghana here. I'm sure it's not different from Liberia. Patrick, is that not the case?
Especially more dangerous, bringing them on the motor vehicle areas, and then these children have to maneuver between cars to get the attention of the people.
Yeah. So it is an eyesore. Meanwhile, most of these who are blind may not be irreversibly blind. Okay, if you have good eye care service, and that's why I think this particular session is very important for you as family care, family medicine physicians, because you see, you don't need a sophisticated equipment to be able to diagnose cataracts. Okay, if you have your direct ophthalmoscope, the last time when we were doing the tutorials, I talked about the importance of red reflex. Okay, if you want to test for the red reflex in this eye, it will be absent. And this one, the cataract is so mature that even without shining any light, you can see that there is some white substance within the pupillary space. That is obviously cataract. So if you see this and you refer to an ophthalmologist, the person can be helped, the cataract will be removed, and the vision will be restored. Okay, yeah. Now, I want us to end with refractive errors. As I said, it's the leading cause of visual impairment. We have about 33 million people in the world who are blind or visually impaired, okay, from refractive errors. And this has a lot of effects. We have 154 million people who have uncorrected refractive error. What that means is that if it's the student who should be in the classroom, because maybe he has refractive error and hence he's not seeing well, it's going to affect his learning. If you have a child who is developing and then the child has significant refractive error, it will affect the child's vision, and hence it will also affect the child's development, because a child needs to see well before he can take the steps to walk. Okay, it can also have economic impacts on the person as well as on the society, because if you are not seeing well, you may not be able to engage in every kind of economic venture. Okay. All right, so I think I have talked about this. Now, refractive error simply means, sorry, there were some slides, I just noticed some slides were missing from this. Sorry about that. I think in a subsequent, I'll try and chip in those slides, but let me, because of the time, let me quickly summarize what refractive error is and how you can pick refractive error, okay? So normally, a normal eye should be able to read up to the 6/6 line. When you check someone's visual acuity and it's not up to 6/6, and it's, let's say, 6/9 or 6/12 or 6/60, or even counting fingers, you go ahead to do what we call pinhole test. Pinhole test. I'm sure you may have seen it at the eye clinic where they check visual acuity. If you check anyone's visual acuity and the vision is not up to 6/6, you have to go on and check what you call pinhole visual acuity. Now, what that pinhole does is that it contains just a small hole like a pin. That's why it's called pinhole. That allows just a narrow pencil of light rays to enter the eye. Okay. If the person has a refractive error that narrow pencil of light doesn't have to undergo refraction. So it means that person will see better. He should be able to read more optotypes or more letters on a Snellen chart with a pinhole if he has refractive error. Okay, so it's something, if you know how to check visual acuity and you know how to do the pinhole, that means you can diagnose refractive error. And you, the family medicine practitioner, may not be the one to correct that refractive error. But after you have picked it, you can refer the patient appropriately to an eye clinic where there is either an optometrist who can correct it or an ophthalmologist. I hope that's clear. So assuming someone's vision or visual acuity is 6/36 in one eye, and then with pinhole, the vision improves to 6/18. It means that person has a refractive error, okay? And we can appropriately refer and advise that patient. So visual acuity that improves with pinhole is refractive error. That's something basic you should look at. However, in some people, when you check the visual acuity with the pinhole, the vision rather worsens. You have that in problems of the retina, especially at the macula, okay? Yeah, so you can easily detect visual refractive error. And we have 3 types of refractive error that you should be aware of. We have myopia, which is short-sightedness, as we normally call it. Oh, sorry, that slide is missing. So we have myopia, which is short-sightedness. Then we have hyperopia, or some also call it hypermetropia, which is long-sightedness. Then we have astigmatism. Those are the 3 types of refractive error. I'll get some notes and send it to you, but let me try to explain. So someone who has myopia will have difficulty seeing things which are far, okay? Every eye has what you call a far point. For someone with normal vision, their far point is usually at infinity. And in ophthalmology, our definition of infinity is a distance of at least 6 meters or 20 feet, okay? So if someone can see something clearly at a distance of 20 feet or 6 meters, that is normal vision. But someone who has myopia or someone who is short-sighted, because his far point is located between himself and infinity, any object that is beyond that person's far point cannot be seen clearly. I am wearing spectacles, as you can see, because I am myopic. I remember when I was in school, when I was in the basic school, I usually had to sit in front of the class. There was a time where I didn't get the opportunity of sitting in front of the class. That was when I realized I couldn't read what was on the boardwalk. So when someone comes to you complaining that he's sitting in front of the class, but still can't see, that person is likely to have refractive error. And this you can confirm by doing your visual acuity and then check whether the visual acuity you get improves with pinhole. I hope that is clear. All right. Yes. So yeah, so that person can be helped with corrective lenses, spectacles or contact lens. Okay. What that is that, you know, someone who is myopic, they could be myopic either because their eyeball is longer than it should be, or their cornea is too curved. Okay, and the more curved the cornea is, the more power the eye has. So if you have rays that are coming from infinity and entering the eye, because the power of the eye is too high, the rays are going to be focused in front of the retina. So myopes will have their images being formed in front of the retina. So to correct it, you put in or you prescribe for them an appropriate negative lens or a divergent lens That helps to diverge the light rays a bit before it even gets to the eye, and eventually help the image form to be focused right on the retina. So without my glasses, my vision is counting fingers, but with my glasses, I can read up to 6/6. Without my glasses, I am very handicapped. I can't drive. I can't do anything. There are a lot of people like me who will come to see you with blurred or poor vision. So if you get that history, it could be suggestive of myopia. Okay. The next one is hypermetropia or hyperopia, that we normally call long-sighted. So the short-sighted person can see clearly things which are near. In fact, no matter how small a text is for a myope, they can read it because their near vision is very good, but their distant vision is poor. A hyperope, on the other hand, contrary to what most people think, that when we say someone is long-sighted, it means the person sees well at far distance and sees worse or doesn't see well at near distance. It's not true. I mean, someone who is hyperopic struggles to see both at far distance and at near distance, okay? But depending on the degree of the error of hypermetropia, the person can manage to see well at far distance. Just a few minutes. The person can see well at far distance. That's because in the hyperope, when you have rays coming from infinity to the eye, a hyperope, unlike a myope may have the eyeball being longer than it should, and the cornea being so curved. So images in a myope will form in front of the retina. But in a hyperope, the images of an object located at a far distance or from infinity will be formed behind their retina. That's because their eye is not powerful enough. So maybe their cornea is flatter than it should be, or their eyeball is shorter than it should be. So because of that, images will form behind their retina. To be able to help them to see clearly, you need to give them corrective lenses, and for them we use plus lenses or positive lenses or converging lenses. That helps to converge light rays even before it gets to the eye, and then the eye's own refractive apparatus can now converge the light feather to meet right on the retina. I hope that is clear. Yeah. So we use negative lenses to correct myopia or short-sightedness, and we use positive lenses to correct hypermetropia or long-sightedness. Someone who is a hyperope and is young may not complain of poor distant vision. The reason is that when the person wants to see clearly at far and the image is formed behind the retina, they can employ their accommodation, okay? They can cause their ciliary muscles to contract and allow the zonules to relax, and then the lens will now assume a more spherical shape. The more spherical the natural lens or the crystalline lens is, the more power it adds to the eye, okay? So that it will help the image, instead of being formed on the retina, to now be formed, instead of being formed behind the retina, to now be formed right on the retina. I hope that is clear.
Yeah.
Yeah.
Yes.
Yeah. So that means if the person is young, and when you are young, you have so much accommodative amplitude. Your ciliary muscles are very active when you are young. But as you are growing, from like every 4 years, your accommodative amplitude decreases by 1 diopter. When you are young, you have about 12 to 14 diopters of accommodation. But every 4 years, it decreases. So by the time this hyperope is about 32 years or 36 years, then they don't have enough accommodative amplitude to be able to see clearly at far distance. And it's even more worrying for them when they have to see things which are near. Because to be able to see things which are near, the hyperope has to correct the defects for distance before he now has to even accommodate more to see as linear. So those people will tell you they have difficulty, especially when they are reading. They haven't gotten to the age where they are presbyopic, like 40 years, but someone as young as, let's say, 20 years, they have headache or their eyes get tired easily after doing near work or after reading, okay? When you check their vision, you may see that their vision may not be optimal, and like we did for myopia, their vision may improve with pinhole, okay? So hyperopes are also there. They may, for the younger people, they may see well at far because of accommodation. But as they are growing and they cannot accommodate any longer, they will not be able to see far again. The third one is astigmatism. They have an irregularly shaped cornea, okay? So light rays in one meridian may focus on the retina. Light rays in another meridian may not focus on the retina. Okay, so they need what they call cylindrical lenses in correcting it. I'm sorry that those lights got missing from this presentation. I'll put them together and then let you have it. Yeah, but I think we can end there. The next time I'll chip in the part about presbyopia. I'm already a bit worn out. Yeah, so I want to acknowledge these references for this talk. Introducing Ophthalmology, a primer for office staff by the American Academy of Ophthalmology. And then I got some information from Vision and Refraction, Orbis International. Those were the parts that got missing. I'll try and get them together. And I borrowed most of these slides from a presentation by Dr. Tae-Yong Han titled Introduction to the Eye. I hope I have not bored you so much and have not ended up confusing you. Thank you so much for your attention, and we hope to build on this basis we have had from this lecture in subsequent lectures. Thank you very much.
Thank you, Dr. Fortin. So
I'll take your questions. If you have any, I'll be glad if you ask questions because it allows us to throw more light on areas that may be bothering your mind, especially in your reading, areas that you may have come across that you don't understand very well. I'm available to help you.
No,
concerning
actually,
what you've done.
Actually, it's not a question. A little bit like when you did mention about the extraocular muscles, the inferior, the lateral, then the oblique. Now, when you have a facial palsy, where there is a visual drooping, where there's drooping of the
drooping of the
because of the question I want to ask, are all those extraocular muscles affected? Affected, in that area, or is that any some of the muscles spared?
Very good question.
Any particular those extraocular muscles that is affected in visual drooping?
Very good. Very good. If we can remember very well, sorry, I think I forgot to mention this. You know, each of the extraocular muscles has a particular nerve that supplies it, okay? So the lateral rectus muscle is supplied by the C cranial nerve or the abducens nerve. The superior oblique muscle is supplied by the fourth cranial nerve or the trochlear nerve. All the other remaining extraocular muscles, i.e. the medial rectus, inferior rectus, superior rectus, and the inferior oblique muscles are all supplied by the third cranial nerve, also known as the oculomotor nerve. Okay, And the third cranial nerve, or the oculomotor nerve, is also responsible for supplying the levator palpebra superioris, okay, the muscle that is responsible for opening the eye, okay, is the orbicularis oculi, supplied by the 7th cranial nerve that is responsible for closing the eye. But the muscle responsible for opening the eye is the levator palpebra superioris. That is also supplied by the 3rd cranial nerve. So the 3rd cranial nerve supplies majority of the extraocular muscle. So the levator, the medial rectus, superior rectus, inferior rectus, and the inferior oblique. The lateral rectus is supplied by the 6th cranial nerve, and the superior oblique is supplied by the 4th cranial nerve. I hope that is clear.
Yep.
So depending on which nerve is affected, you have some particular presentation, okay? So when someone has stroke, that's affected maybe the nucleus of the 7th cranial nerve or the facial nerve. That person will not have any problem with motility of the eye, because the 7th cranial nerve does not control motility of the eye. It is only responsible for the orbicularis oculi, which is responsible for closure of the eye. Okay, that's where I mentioned that they may present with tearing symptoms, because as the orbicularis oculi contracts, some suction mechanism is set in place to let the tears drain from the inferior fornix of the conjunctiva. Okay, when someone has a problem with the 6th cranial nerve, it means that the lateral rectus is not working. So the medial rectus will now pull the eye towards the nose. So the eyeball will be deviated medially, okay, when there is a problem with the abducens nerve that supplies the lateral rectus. In the same way, when someone has a problem with the 3rd cranial nerve, which I said supplies the medial rectus, inferior rectus, superior rectus, and the inferior oblique. If there's a problem with the oculomotor nerve, it means that the other muscles, that's the lateral rectus and the superior oblique muscle, have a free room to operate, because the action is not being antagonized by the action of the other muscles. So in a 3rd nerve palsy, what you classically see is the person will have ptosis. The person will have drooping of the upper eyelid, and then the eyeball will be noticed to be looking down and out. So it's looking out because of the action of the lateral rectus, and it's looking down because of the action of the superior oblique. If you can remember very well, I said that the superior oblique augments the action of the inferior rectus in moving the eye down, okay? So I think this is very, very important, because you may have someone presenting to you with a 3rd nerve palsy, okay? And some 3rd nerve palsies could be life-threatening. When someone has an aneurysm, an aneurysm of the posterior communicating artery in the brain, that portion can it's very close to the course of the, or like to the pathway of the oculomotor nerve or the third cranial nerve. So that aneurysm will compress on the external fibers of the third cranial nerve and can present with ptosis of the eye, and then the eye being deviated out and down. And you may see that the pupils are involved, okay? The pupils will be dilated because the pressure on the external parts of the 3rd cranial nerve, the 3rd cranial nerve's external, carries the parasympathetic efferent pupillary fibers from the Edinburgh nucleus. So if there is any pressure there, that person is said to have a pupillary involving 3rd nerve palsy. that can be potentially life-threatening because you may have an aneurysm that is only waiting to burst. So depending on which particular nerve is affected, there will be some classic presentation. I hope that is clear.
Yeah, thank you. Thank you.
You're welcome. So any other question?
Yeah, it's okay. I don't know whether there's other colleagues.
Yeah, I think most of our other colleagues have joined the other lecture. If they watch the recording later and they have any question, they can channel them to you. You can send it to me by WhatsApp, or you can share it on the Google Classroom page. And Patrick, I think let Cynthia show you how she was able to log onto the Google Classroom. I've still not been able to have you on it so that we can continue learning over there outside this seminar period. Okay, you can have as much contact time as possible. All right. Okay. Anybody who wants can sign up to that Google Classroom. Any of the other residents who are not in the ophthalmology block now, who want to join, they are all free to join. Even after this session, I'll be willing to share material there.
Okay. Thank you.
Thank you.
You're most welcome. Yeah. All right. Meeting ending.
Thank you.
Yeah. So when is our next session? I think, Patrick, tomorrow we have a tutorial, right?
Yes.
All right.
When? What time, Doc?